Acute respiratory distress syndrome. The objectives of the following slides include
to refresh the knowledge of the working nurse about the causes, etiology, signs and symptoms, and diagnosis of acute respiratory stress syndrome.
To inform the working nurse of usual treatment and current developments of treatment.
To highlight recent research that provides evidence of the benefits of utilizing the prone position in improving patient outcomes.
And to highlight the important nursing implications when treating patients with Ards. Acute respiratory distress syndrome is a life-threatening lung condition that prevents enough oxygen from getting to the lungs and ultimately into the bloodstream. Ards is a sudden failure of the respiratory system. It can develop in anyone over the age of 1 who is critically ill. Ards can be caused by any acute injury to the lung. Causes of Ards include sepsis and shock, trauma, forced or blunt, pneumonia or various types of lung infections, including bronchitis, multiple blood transfusions, aspiration, inhalation of harsh chemicals, narcotic use, use of sedatives, as well as overdosing. Ards is a serious and life-threatening syndrome, and the mortality and morbidity includes over 190,000 Americans are diagnosed with Ards annually. 1/3 of the patients diagnosed with Ards do not make it out of the hospital alive. Treatment modalities for Ards has greatly improved. 20 years ago, the mortality rate for Ards was 50 to 70%. Today, 30% of all cases can be fatal. The etiology of Ards. Fluid begins to build up in the lungs, which in turn prevents oxygen from reaching the lungs and ultimately the bloodstream. Lungs become stiff and non-complacent. Despite mechanical ventilation, a patient with Ards is unable to maintain oxygen needs to the body. Signs and symptoms. Ards typically occurs with other organ failures. Difficulty breathing can occur, low blood pressure and organ failure, shortness of breath. Often signs of Ards develop within 48 hours of injury. Patients can be so ill they cannot complain of acute distress. Signs of Ards are related to decreased oxygenation, rapid breathing, low oxygen blood level or low pulse oximetry, cough and fever, confusion, and extreme lethargy. Tests for diagnosis include arterial blood gases, which can be done by nurses or respiratory therapists, blood tests, lactic acids, blood chemistries, cultures, a CBC, bronchoscopy, chest x-ray, sputum cultures.
Usual treatment of Ards includes endotracheal ventilation with mechanical ventilation at low tidal volumes in combination with positive end expiratory pressure, or PEEP. PEEP works by maintaining pressure inside of the lungs at the end of expiration. Evidence has shown that the combination of these two ventilation therapy prevents the alveoli from distending, which can harden the tissue and make oxygenation of the blood difficult. Proper fluid management or maintaining minimal levels of fluid can reduce ventilator days and ICU days. Failing organs as a result of Ards is also of utmost importance. It is important to understand that the management of Ards is directed at the care of the problem, as previously mentioned, along with supportive treatment for ventilation. Ventilation strategies. The new standard of care now includes low tidal volumes, or 6 milliliters per kilogram of ideal body weight, in combination with controlling plateau pressure or pressure applied to small airways, which prevents excessive alveolar stretching and ventilator injury. Evidence has shown that that high-frequency oscillatory ventilation delivering small tidal volumes at fast frequencies reduces the likelihood of air trapping because inspiration and expiration are kept active. Pharmacologic treatments for ARDS include nitric oxide, which is a questionable medication due to the lack of evidence of long-term benefits. Evidence has only proved that nitric oxide improves short-term oxygenation. Corticosteroids, when started early, that is within the first 14 days of diagnosis, at moderate doses with a gradual tapering, has shown a significant decrease in inflammation and an increase in oxygenation and ventilator-free days for patients. Surfactant, or artificial surfactant, has been proven to increase oxygenation, but no proof exists for an increase in mortality. Albuterol decreases airway resistance from stiff lung tissue. There is no evidence about mortality concerning albuterol. Most drugs ease the process of breathing. However, little evidence leads to proof of survival. The prone position, or having the patient lying face down, works by improving matching of ventilation, or the exchange of oxygen and carbon dioxide, and perfusion, or the speed of blood through the lungs. The difficulty in the prone position is that it takes an excessive amount of staff, and to place the patient in the position, it takes 6 nurses and an anesthetist. Though significant improvement has been shown in terms of oxygenation with potential survival, there lacks evidence or studies providing evidence of increased survival. It is not suggested for multiple trauma or brain injury patients. Nursing implications for treating patients with ARDS includes supporting the family by empowering them with knowledge, explaining the evidence surrounding the benefits of placing the patient in prone position, and return advocating for early intervention with the medical team. In addition, nurse-led treatment charts for people with respiratory failure and pulmonary complications in which there is a list of interventions. It's important to place the prone position as an initial option for treating a patient with ARDS to increase their survival rates. That concludes our presentation on ARDS.